So for the guys who tuned in, let's do the quiz. So the quiz is up there. It's a bit of entertainment. More importantly, it's actually a bit of education. And if you get up there first, you're going to get some GIEQs coins.
So vote now.
Yeah,
and the first one's the winner.
Vote now, otherwise you've already lost.
You've probably lost to Don McIntosh. He's probably still awake, so voting in the quiz.
Right, so the great thing about the quiz is, I think at the end of the talk, you should get the quiz right. So even if you've had a go and it isn't quite right, we're now going to find out what the right answers should be. So without further ado, I'm going to invite Peter to give a talk on, I found a polyp in the duodenum. What should I do?
Thank you very much. So these are my speaker disclosures. So, of course, duodenal polyps, you have several kinds of duodenal polyps. Some are very specific for the small bowel. Some are rather non-specific, and we see them also in the colon. But I will focus my talk today only on the duodenal adenoma because of time restrictions. So what's a typical case that we encounter in clinical practice? So here, 81-year-old patient, no significant comorbidities, and he just got a gastroscopy for pyrosis, and you find one of these lesions. So the left lesion, flat adenoma, small size, middle lesion, an ampuloma, so an adenoma involving the ampulla, and then at the right side, really a laterally spreading large.
Peter, you've got the name of Mia Klein on your slide.
Oh yeah,
so that's the guy who you're citing on your slide.
Very honored that he is also online joining the discussion. Thank you, there. Okay, so. Yeah, then of course, if you have this, then you have to make a decision. And what's the problem with duodenal polyps? That, well, you have a risk of disease-related complications and risk of death due to the disease. It's mainly determined by the polyp size. Are there any signs of invasive cancer? Is there an involvement of the papilla? But also you have the risk of treatment-related complications, and you have a risk even of death due to the complication. And this is mainly dependent on age, comorbidities, and also the involvement of the ampulla. So some facts maybe to start with and to consider. Most duodenal adenomas progress to cancer in a sequence that is similar but slower than that for colonic adenomas. They are not innocent. It's maybe a misunderstanding that duodenal adenomas are innocent. It's not true. About 30 to 85% of the duodenal adenomas will progress and undergo malignant transformation. High-grade dysplasia diagnosed at first biopsy or a large lesion diameter are significant predictive of progression to adenocarcinoma.
So I'm just going to hand over to the room. So we've got Dominique de Wolf in the room. Is that correct? Can you hear us?
Yes, we can hear you.
Fantastic. Do you want to take it from us?
Okay.
Okay, so we are going to start first with presenting the case. It's a 51-year-old male. In 1984, he had a colectomy because of FAP. In 2018, he had an ESD of a duodenal tubular adenoma with high-grade dysplasia. Also, he had multiple polypectomies in the pouch and the duodenum, and also he has gastric polyps. In 2020, he had a papillectomy of the major, and in June this year, he had a papillectomy of the minor. So the main focus for the endoscopy today is a reevaluation of duodenal polyps.
So, you heard it's a patient with familial adenomatosis. I'm coming here in the bulb. First of all, you see in the gastric region multiple small polyps, hypoplastic polyps that you see a lot in these patients. We don't think there are some very big polyps that need to be resected in the stomach. When we pass the pylorus here, we use also always the cap on the scope because it's much easier to find a good position in the duodenum. You already see some small polyps here in the bulb. And if we turn right, you see multiple small polyps into the duodenum. I've seen that here deeper on in the second part and even in the third part of the duodenum, there are some small polyps, also maybe some larger polyps. But unfortunately, I make a big loop in the stomach, and even with aspirating the stomach, it's not possible to go further in the third duodenum. So I think after this scope, I have to change to a pediatric colonoscope to try to resect this one and maybe a polyp that's a little bit further on, but that I cannot reach at this moment. So when I come back here, I come back in the bulb, and I think this is the minor papilla, probably, which is in the duodenal bulb. I'm not sure. Patient had an ampulectomy of the minor papilla, but I'm not sure if there's no remnant here.
So Dominic, I'm going to be a little bit rude and ask you to just hang fire, because in the other room we've got an active bleed. So we're just going to switch. I apologise. We're going to switch the other room.
Oh.
So this is an acute bleeder that's presented to the hospital that they brought down to the department for
John.
emergency treatment. Ah, David, you're with us.
Yeah, we've got something great for you, John. I'm so sorry that we're not going to have time for the polyps. We'll put them all on Geeks Online for you, okay? All of those beautiful duodenal polyps I'd lined up. I spent hours making them just to show you, John and Peter, but I don't have time for that. So they're all going on Geeks Online. And can you see the endoscopic image?
We can, perfect.
So patient is about to be explained to you by Zander.
So this is a special present. It's an 82-year-old patient who was electively admitted to vascular surgery for an elective procedure. He has a history of COPD and severe cardiovascular disease. The attending doctor noticed a hemoglobin fall from 15 to 8 grams per deciliter, and also melena. So the patient is currently getting transfused and has PPI in high dose. And now we're doing the endoscopy.
So you might have already seen the hemotin around, the hemotin staining. I was expecting fresh blood here, but I mean, let's just look at this. So the guy's dropped a significant amount of hemoglobin. I'm here with Lobke. Lobke, what are you seeing there?
Yeah, so we didn't see any blood in the stomach nor in the duodenum, and we thought, won't be much going on. Then we saw this black pigmented spot, but when you looked closely, we saw something else, didn't we?
Yeah.
It's not a black pigmented spot, it's probably a clot, no?
Yeah, I mean, John, what do you think? So we see this pulsing. I mean, just look at it closely. There seems to be some pulsation going on behind here. It's difficult I mean, can't see anything else if we look in the rest of the duodenum, apart from a bit of food. This is the culprit lesion, right?
It's likely to be the culprit lesion, and in fairness, in my own practice, David, I will move the clot, because it's very difficult to treat the condition without the clot. Now, you very skillfully and second lesion.
Another great. What happened there?
You found the culprit.
Well, I mean, but that's a really important reason to use a cap, no?
For sure, absolutely, for sure.
So let's have a look at that one a bit better. I'm just going to keep my clockwise rotation on, because that's the way to stay in the duodenum. And as we come back around, so this is posterior duodenal wall between D1 and D2. There is this thing. Very difficult to see. So maybe we first investigate the number one and see what's underneath that hemotin. Should we try that, John?
I mean, I think that's what you have to do, David. I mean, the problem is if you look at that and say, well, that's just got a bit of hemosiderin in the base, it requires no endoscopic therapy. I think you're going to miss out on some active bleeding lesions which would benefit from endotherapy.
Okay.
You know? So I think you have to see what's underneath.
So we'll use the gold probe, just because I have it here, to jet some water at it and see what happens.
So for the guys who are watching, the gold probe has water in it, and as you're applying the heat, you apply the water to help cool down the tip as you're applying the thermal energy. So it can function as sort of an irrigating machine there.
So we're going to go harder with the water pressure. Really try and destroy this. I mean, I don't know whether, John, you think we need to be removing this, because I'm not seeing too much under here.
So I think that's probably okay, David.
Let's just make sure we get all of it on.
David, quick question. It's Samir. How are you?
Hey.
So when you're trying to investigate a clot or remove a clot, do you prefer to inject prior to
Small vessel.
I see a vessel.
dealing with the clot?
Say that again, Amir. I can't hear you. Maybe we can turn the sound in the room up.
The question is if you would inject first.
Adrenaline?
Yes, before you try to remove a clot.
I never do, Amir. I have to be honest with you. I don't do that. But yeah, I think it's not a bad idea to pre-treat if you think. So what do we think about this?
So can I just say I support Amir. So the evidence suggests that you should have at least dual therapy. So you need to inject something, I think.
Okay. Yeah. I mean, don't you think that most of that evidence, John, is quite old now?
Yeah, but you know, I don't see a downside, David, because you're about to noise up a vessel here, you know.
Noise up a vessel.
And what normally happens is, I think what Amir's alluding to, and I think what puts people off is you displace the clot and then you've got blood pouring out. Whereas if you do an injection, submucosal injection of adrenaline, it doesn't have to be adrenaline, it could be anything actually. It just makes that bleeding less profuse, and I think it helps with the visualization.
I mean, let's just pause that discussion for a minute. This is a vessel, right? Perforating through the wall of the D1.
Yeah.
Let's leave the other one alone a minute and just think about the treatment of this one, although we go back to it in a minute. So we're just demonstrating the cap against the mucosa underwater technique. You really can get great imaging with this. Amir, what are you thinking when you look at this? I mean, looking at the ESG guideline, the most recent one, the evidence for this size of vessel for me would be with some significant mechanical therapy, right? Not the heater probe.
No, I think the gold probe is an excellent. Again, I agree that you need to do two modalities: inject and then do a gold probe, which also gives you the tamponada effect.
So you would gold probe this?
Yes, after injection of adrenaline, yes.
And John, would you gold probe this?
I definitely would gold probe this. I mean, the problem with the mechanical application is that is the age of the ulcer. So once it's been established for a little while, it becomes very fibrotic, and then you run the risk of not actually getting the vessel, but you've then got a clip in your way for any further therapy, and that's a real issue. And you can see this vessel's coming through the mucosa, right? Because there's a gap there.
But it's coming not just through the mucosa. I think it's coming through the muscle, isn't it?
Yes,
I mean,
it's perforating through the muscle. So this is quite a big vessel, David.
I mean, what I think is from the... So I disagree with both of you here, and this is really a very interesting debate now, because I think that this is precisely what the ESG guideline suggests as OTSC as the first line of treatment.
Is there a place for hemostatic forceps?
Who is asking that?
Christophe here, David.
Christophe, well, for me, not, eh? So for me, this is sort of something that, I mean, look, if you see this, you can clearly see it's coming through the...
But how much is the diameter of it? 2 millimeter, 3 millimeter? You can still apply gold probe in this case.
2 millimeter? I think it's bigger than that, no?
Oh, yeah.
Here's the tip of the gold probe. How wide is the tip of the gold probe?
David, it's smaller than the gold probe.
It looks perfect for sealing with the gold probe.
So what I'm going to do then, because I got it here, is we're going to use the gold probe, right? And I'm not... 2.3 millimeter. Okay, I'm not going to inject adrenaline. So we'll see how that goes. So John, you want to talk through the technique of using the gold probe?
Yeah, so there's a couple of things about the gold probe. You need to set the energy level, and then you need to have a combination of thermal and mechanical pressure. So I talk about leaving a footprint in the snow after you're finished with the gold probe. So you need pressure. The cap helps that because it allows you to put some pressure as you apply the energy. So you need to apply the energy. You need to have some fluid coming out the end of the gold probe, otherwise it will stick to the vessel and you'll end up in a really bad place.
So let's switch to the... So we're going to switch the water to the gold probe. What energy do you normally use, John?
Please, you answer me that. I'm going to palm that off to someone else because I've been speaking all day.
Amir, what do you think about what energy you're using with your gold probe? Sorry.
It is a bipolar energy, huh?
Mm-hmm. Yes, it's bipolar.
Yeah.
So that means you don't have to set the energy? I'm just playing the devil's advocate for the audience.
You need to dial something into your machine.
Okay, what's dialed into the machine? 4.0, John.
Yeah, you're using a new Vio 3, aren't you?
Yes.
It's slightly different to everyone else on the call who's still, not that modern.
We can convert it though, so I think what we've got actually is 73 watts. How about that?
In watts?
That's quite high, David. Yeah. That's quite high.
Okay. Should we turn it down a bit then?
I would.
To what?
I would probably give 20-watt bursts and probably do more than one. is what I would do normally.
Okay, let's turn it down to 20. Lob, what do you think?
Yeah, I agree. I would do the gold probe myself. I would not have done the Ovesco. I wonder, for the technique itself, so this is going to be very interesting to watch it. I've used it the other day. I'm just going to compare what I did to what you did. But one thing I'm worried about here, you have to make sure that your tip is far enough out not to damage the scope. Is that right?
Important. So we're far enough out now. And what about the pressure that I need to apply on it?
Yeah. So there's two things about that, isn't there? You can you don't want to go through it either, do you?
I definitely don't want to go through it, and I think it's nearly, well, it's already halfway through.
Yeah.
John, what do you think? Push hard on it or not very hard on it?
I think you need firm pressure. It's not that it's nearly through. It's perforating from below. So that's its normal track through the muscle there, which is split, I think.
You need to collapse the vessel for it to coagulate it. Otherwise, it's not like an APC that is monopolar that you have to be far away. You have actually to contact and do pressure to collapse the vessel.
You have to be contacted. All right. So we're contacted with it. It's underwater. Does that matter?
No, not for bipolar. Peter's looking very thoughtful, though.
Peter, let's hear what you're thinking.
It's a very interesting discussion, because I must say, if you're convinced that this is a culprit lesion, if I would have seen this vessel, I would also go for an over-the-scope clip. And it's not because
thank goodness. There's some support, Peter.
Yeah, but it's not that we always agree, David? So
that's
it's
true,
not
but
because
in this moment we found agreement.
But I think that it's in my personal experience, the only treatment where you are sure that there will not be a rebleeding afterwards.
But let's try the gold probe, right? So I've got firm pressure on it. I'm making sure my scope is stable, right? Because this is really feeling like it wants to fall out. So we, of course, while we're mid-heater probe, mid to gold probe, don't want to fall out. And how long of a burst am I going to apply moderation to this?
That was something what I would like to add, David. That it's important to count because people are very afraid and they tend to stop after 2 seconds. So I was teach to
what
always
am I counting
count
to
10.
though, Christoph?
No, not to 2.
5.
In fact, the nipple that you have now has to become a dimple.
Yeah, I agree. It has to become a dimple.
Just get a big one.
And you'll see the effect. You'll see the effect, David, as you.
Yeah, that's fine.
We do 10 Mississippis, David.
Sorry, what's that?
10 Mississippis.
10 Mississippis.
Yeah, you're making me really back in there. Okay, I'm going to go. Right, so 5 seconds. Ready? Maureen, are you going to count for us? Maureen,
It is the anterior wall.
you're going to count for us. I need you to count to 5.
From
Ready?
5 down or from 1 to 5?
Doesn't matter. You can decide yourself which of those you do. And we're going to start when you hear the pedal. Ready?
Ready?
I'm loving it. They're going.
Go.
They're going 10
1,
in Israel. They're very
2,
brave.
3, 4, 5, stop.
Mississippi. Right.
10, he said.
So I filled it off without any water. Why did I do that? Because there wasn't any resistance at all. Does that matter, John?
Well, no. It's fine. I'd probably stick it on a second time though. I'd have gone with Amir and do 10. I mean, that's perfect for that.
It's not a little bit in the left. In the left.
In the left?
You want to see a bit of depression. That's much better. You're burning the thing now, you know.
All right, and let's have another look at it now. We'll add a bit more water, and then we'll go for some more counting more in if we have to do it again.
Yeah, it's in the left.
That's a good job.
Yeah. Now it's on the 3 o'clock.
Maybe.
Yeah.
Has it gone now, that vessel?
Well, the vessel's floating in the breeze, David. It's the thing that's.
Or is it that thing underneath there?
Yeah.
This.
That's the vessel.
Yeah.
Right.
Yeah.
So that needs more treatment, right?
Still a nipple.
Okay.
So push.
Ready?
I can assure you, Dr. Anderson, I am pushing. All right.
1, 2, 3, 4, 5, and stop. That was 6, actually.
Okay, now it feels like it's stuck on. So now we're going to flush down the thing. Have we got the flush and the attached to the gold probe? Okay. So now I'm watering as I'm coming off. All right. Okay, guys, it's a battle between Ghent and the rest of the faculty as to whether this is going to work or not. So we better.
What do you think of that, Christoph?
Let's have a water
It's
down the scope.
almost a dimple, but not quite.
Not quite. Yeah.
More?
Yeah. I would, yeah.
Yeah, you should have listened to him. Yeah, he said 10 off the bat.
Yeah.
Or is it, now it's at 15, John.
That's because he didn't push
But
hard
no
enough the first
Mississippi's.
time.
So
No
it's less.
Mississippi. But what I'm saying to you guys and the people who are watching this are obviously interested. How many times do you do this? Down the scoping. Before you decide to go with the obvious logical treatment.
No, you need to seal the vessel, David. I just think the anterior wall is perfect for the gold probe.
But is this sealed now, John? That's what I'm asking you.
It probably, but I'll probably do a little bit more. I mean, the problem is in the other side of the thing where the vessel's a hell of a lot bigger. And I
Here?
wouldn't be waving the gold probe in the other one.
You mean the bigger ulcer?
Yeah, but it's also inaccessible. So
Well, don't worry about that. We'll come back to that in a minute. So this one, does it need more now?
I think it's pretty
Amir,
much.
what do you think?
I think it's pretty good.
Okay, that's an interesting point of view.
would
What
go-
Lobke's saying more in my ear. The nurses
go
are
for
waving them hand around saying they want me to do more. John thinks I'm not doing anything really useful here and I should be treating the other vessel in the other ulcer. And Christoph and Peter, you're quite quiet there.
I would go for more.
Okay, Peter? Was that you?
Yeah, I would go for more, but I would go for clipping. So,
How great is this
but
discussion?
I don't think. I mean, I've never experienced any perforation with the gold probe. You should really do your very best. I think.
Right, so I
to-
sit here for another 20 seconds or something on it?
10.
10.
Okay, 10. Right, ready? 10 Mississippis, Maureen. Are you ready?
Not so
I'm
fast,
ready.
Maureen. Not so fast.
Okay.
Ready. Go.
Ready?
Don't fit.
1, 2, 3, 4, 5, 6, 7, 8, 9. Stop. Thank you.
You were made for moments like this, Maureen. Have we got a... is it down the... Which one is it on? The scope or the... Can we have it on the... Yeah. Sorry, we're using the same water jet to flush down the gold and down the thing. Yeah, okay. So water coming down the probe. Pulling it off.
Is there something to say for this? I know you
Well,
really,
not yet, but-
you're really keen to put on an over-the-scope clip.
But
But will it not be much harder to assess the other ulcer then? Because
yeah, well,
of
we
the
got.
tissue
I think that's a
density in a
really
way?
important point.
Indeed.
So this is safe for the moment. I'm not convinced that this is sorted out. I think we're pretty much all the way getting through the muscle here, but all right. Let's just look at the other one.
But we can call John this night, eh?
Yeah, so Anderson, because you just wanted to go with the 25, 30 seconds of gold probe, I'm calling you tonight.
Can I just say, you didn't do a pre-injection.
Oh, because that would have made a significant difference here.
Well, you never know. It might have just made the vessels a bit smaller, more likely to clot off. I mean, all bleeding stops eventually. It's just whether the patient's still breathing at the end of that process.
Yeah, my God. Okay, let's have a look at this other ulcer. So we're at the posterior wall of the wall. Very difficult to stay there. My apologies.
Yeah, let's put an Avesco clip on this one. That'll be fun.
That's also possible, John. You want that now?
No, but all I'm saying, David, is people do things because they're easy. I was being a bit flippant, but because it's in the anterior wall and it's really easy access, you can put an Avesco clip on. Everyone think, well, I could manage that, you know, because it's a pretty clunky piece of kit, and it's a bit like cracking a walnut with a sledgehammer, as we say in the UK. I think it's overkill. I think what you've done is fine. I would have put a bit of injection on. When it becomes a little bit more awkward, people are less keen to do things because they just haven't got access. And I think there's a real problem at the moment with treating GI bleeding as people get less and less exposure to acute care, that they stick something like a hemospray down here and just spray it and leave it till the next day. Now, actually, in the fullness of time, evidence might suggest that's fine, actually, for a lot of lesions. But no, you've got a big vessel. You know, the hemospray will just temporize it for 24 hours. Now, it may well allow then the department to get their best endoscopist to have a go the second day. But I think our approach to GI bleeding is changing. But best practice, I think, is dual therapy. And then you have to decide on the therapy depending on the ulcer, both in location, but also in the chronicity of the ulcer, because the physics changes, of the physiology, rather, changes of the mucosa. And mechanical things become much more difficult with chronic deep ulcers.
Yeah, but I mean, I think it's actually one of the advantages for me of the over-the-scope clip is that it's maneuverable, like it's got a cap on it. You can apply it wherever you want to apply it. If you want to apply it to this posterior part of here, you definitely could. I mean, so that for me is not an issue. I also don't think it's necessarily easier. It certainly costs a lot more money. So we don't want to apply it if we don't have to. So I was just looking at this, and you saw a fleeting glimpse of that. It's very hard to stay on it, even with a cap on. What's our opinion, of those of you watching this, about what we're seeing there with this other ulcer in the posterior duodenal wall? You've got these two little ones. I think these are nothing. And then you have this one right on, as they always are. Side view, would that help here?
It's pointing the wrong way.
Not for the posterior wall, I think.
It's pointing the wrong way.
So that's an important point to make to the audience, that this side view is not going to help you here. What do we think about? So I've got it in a better position than what it was in before. So there is probably a vessel in this one as well, hey?
I'm not sure.
Who's saying that?
Suzanne.
Suzanne Ribeiro. And what about the, are you sure about this thing underneath the thing in the middle? It's hard for me to move it, but that's not a vessel, that there?
It looks like mucosal damage, but yeah, I would check.
That there? Now at the 5 o'clock?
Okay.
Who thinks that's a vessel?
You paused already a lot of times. I think if it was a real vessel, it would have started to bleed.
Really? So that there's not a vessel?
The ribbons that you've got coming across the centre of the field, David, if you trace them back to the base, you'll find the vessel.
Well, that's what I mean. That's what I'm saying.
So trace the ribbons back to the base.
Exactly. There, right there, at the base.
Yeah.
But do you think that's a vessel, John?
Well, there is a vessel there. Whether it's actively bleeding requires treatment is another discussion.
But it's there, right? You can see it.
Okay,
it is there, yeah.
So that's Suzanne. Have I convinced you?
I'm not convinced yet.
My God.